So next up, we've got Jessica Eccles, who's a psychiatrist who trained in Cambridge, is now in Brighton, doing some fascinating research into the interaction between hypermobility and psychological symptoms. So thank you so much, Jessica.
Okay. Do I just press this slide? Oh, here it is. So hello, everyone. Thank you so much for inviting me to talk to you today. And I wanted to just tell you a little bit about what I do. So I have, for the last 9 years, been a clinical academic psychiatrist based in Brighton and Sussex Medical School, working with Professor Hugo Critchley. And I now spend 4 days a week doing research into hypermobility and related disorders, and 1 day a week with my colleague, Professor Neil Harrison and Dr. Alessandro Colasanti. I work in a very exciting new service called the Immunopsychiatry Service, which is where we see people with comorbid inflammatory disorders and treatment-resistant affective disorders, so bipolar and depression. And interestingly, that this work, which is seemingly slightly unrelated to immunopsychiatry, appears in my clinical practice to be very relevant. I'm also in the process of trying to develop what to other purposes you might call a psychorheumatology service, so an integrated liaison service for rheumatology patients. And rheumatology is where you may find most patients with hypermobility and related disorders, but I hope to show you through the course of this talk that hypermobility you will find in every clinic in the hospital. So a brief thank you to the funders. Most of the data that I'm going to talk to you today was funded by the MRC through my clinical research training fellowship, but the work that this has led to is now funded by a mental health charity called MQ and Versus Arthritis, who formerly known as Arthritis Research UK. So, hypermobility and autonomic dysfunction, insights from bench to bedside. I know this isn't really an interactive forum, but I just wanted to get a sense in this esteemed room of how many people feel comfortable kind of recognizing hypermobility. I can't even see you, but a few, a fair number. Yes. So I will talk in a moment about how the nomenclature of hypermobility has changed a lot in the years that I've been working in this field. But essentially, the picture that this depicts is something called the Byton scale, which is a very, let us say, crude way of looking for hypermobility, which is essentially abnormal joint extension. So this is a score out of 9, and you score 1 for each maneuver on the left that you can do on both sides, and then finally 1 for being able to put your hands flat on the floor without touching your knees. Hypermobility, obviously, is a disorder of connective tissue, but I remember when I was being examined for my PhD by Mark Edwards and Nick Medford, they were very keen to know the exact pathophysiology of this connective tissue. And the more I looked into it, the vaguer it is, but it seems that it's likely a disorder of collagen type 3 compared to collagen type 1. Hypermobility in and of itself is not necessarily a problem, and in fact for many conditions is many careers is an absolute asset. So most ballet dancers, gymnasts, musicians are hypermobile, and it is advantageous. But we know from work, particularly I think in the Royal Ballet Corps, that more people are hypermobile when they enter ballet school than when they leave ballet school, which poses a really interesting question. Did they become less hypermobile? The answer is, in all likelihood, no. The hypermobile people experienced more injuries, and therefore they had to leave or drop out. So it is absolutely an asset, and we'll have all seen people on the television or in magazines who are clearly hypermobile, and it can be a real asset. But it is also
known to be related to a variety of musculoskeletal conditions, so particularly chronic pain, dislocations and subluxations. And so when someone who is hypermobile also experiences symptoms, I like to think of them as having symptomatic hypermobility. This used to be called, and there are a variety of names, and I'm quite agnostic about what is actually the best way to describe it. This used to be called joint hypermobility syndrome, and formerly EDS type 3 or EDS hypermobility type. That nomenclature changed in 2017 through international consensus. It is not based in research, it is clinical consensus. And we now talk of two different conditions, well, two related but similar conditions: hypermobile EDS, hypermobile Ehlers-Danlos syndrome, and also hypermobility spectrum disorder. Hypermobile EDS has very clear criteria which you either meet or you don't. Hypermobility spectrum disorder means if you have any hypermobility and symptoms that are in hypermobile EDS, then you get a diagnosis of that. But there is no current new research criteria to diagnose these. So when I go through my work, I will be using something called the Brighton criteria, which remain the only validated criteria but have been clinically superseded. So as I like to tell medical students, connective tissue is in most places of the body. So people with hypermobility have a variety of extra articular manifestations. So there are things like that are very common, like having flat feet. And then there are pain conditions, things like fibromyalgia, which I'm currently doing another large research project into mechanisms of chronic pain in fibromyalgia and ME/CFS. So that there's a lot of pain. There are interesting skin signs, so stretchy and skin and smooth skin, and papyrus scarring, things like abdominal hernias, easy bruising. Obviously, there's a high there's an overrepresentation, significant overrepresentation of people who are hypermobile in functional gastrointestinal disorder. And that may make some sort of sense in terms of the connective tissue problems and how that affects motility. Then there are various cardiovascular and urogynecological conditions, dental things that often go with, say, temporomandibular joint dysfunction and neuralgia, and also why we're all here today, the neuropsychiatric phenomenon. So I'm going to talk a lot in more detail about dysautonomia, but we also know that people with hypermobility are more likely to have proprioceptive difficulties and to be dyspraxic. They have some interesting pain, so that they're kind of hypersensitive to pain, and also possibly there is some literature to suggest insensitive to local anesthetics in some cases. More people with hypermobility and related conditions seem to experience fatigue. And I was recently awarded a grant to explore brain mechanisms of this interesting topic of brain fog, and we can perhaps think a little bit about that later. There is talk of cognitive impairment in hypermobility, anxiety, which is obviously what I'm going to be talking a lot about, problems with hyperosmia and hyperacusis, so sensory sensitivities. And I'm just going to show you some. I don't want you to read all of this slide. In fact, I'll go back and for a sec to explain it a little bit better. But obviously, I'm a psychiatrist. Why am I interested in a connective tissue disorder when there isn't actually that much connective tissue in the brain? And the reason is that there has been for a long time a very clear link between hypermobility and anxiety. So a group in Spain in the 90s did several case control studies, and what they found is they took 100 patients with panic and anxiety disorder and 100 medical controls. And the medical controls, about 15% of them were hypermobile, according to their criteria. And in the anxiety and panic population, about 67% of them were hypermobile. So a really striking difference. And I'd never really thought about this, but actually there is a really lovely animal model for hypermobility and anxiety, also from Spain, in that you can measure the hypermobility of dogs. And dogs with hypermobility are more likely to experience thunderclap phobia. An interesting aside. So there have been consistently study after study showing the relationship between hypermobility and anxiety disorders, anxiety levels, and also anxiety relieving behaviours. So evidence to suggest that hypermobile people are more likely to smoke, drink, and eat chocolate, and that correlates with their fear sensitivity. So lots and lots of research, and this is a meta-analysis of nearly 4,000 participants in studies. They're talking about this term benign joint hypermobility syndrome, which is now a redundant term, and in fact the literature is very confused between people with what we call generalized joint laxity, asymptomatic hypermobility, and people with symptomatic hypermobility. But regardless, if we take into account those methodological differences, people with hypermobility experience more intense fear, and they have an odds ratio of 4.39 of anxiety, 4.10 of depression, and 6.7 of experiencing panic. So this is meta-analysis from 4,000 people. I have recently, and I can't go into details because it's under submission, but conducted using longitudinal data, have found that having hypermobility in a large population study at 14 predicts being anxious and depressed at 18 and is mediated by heart rate. But hopefully there'll be more. I'll be able to talk to you more about that another time. And then, if you recall from my first slide, the things about dyspraxia, hypersensitivity to smells and sounds. I'm not going to ask you, but what kind of conditions does that make you think of? That makes you think of, is there a relationship between anxiety and neurobehavioral or neurodevelopmental disorders? And it's that very question that aroused the interest of my then supervisor, Professor Hugo Critchley. He was doing a brain imaging study of as what was then known as Asperger's syndrome. And he thought to himself, and it was something to do with the shape of people's heads, that there was a certain look to the type of patient male patient that he was putting in the brain scanner. And he thought to himself, I wonder if there is an association between Asperger's and being marphanoid, which is a hypermobility-related condition. And indeed, there were several case studies linking the two, and now the whole population of Sweden attests to this link. So in some countries, our country does not, have very good national registries. So in Sweden, looking at hypermobility, they've called it here EDS, they find that the relative risk of autism spectrum disorder given hypermobility is 7.4, and an ADHD 5.6. And I did give a members platform talk a couple of years ago, actually, about my own work on hypermobility and autism, ADHD, and Tourette syndrome, where we are finding about 80% of 80% of neurodevelopmental patients who are female have hypermobility, and about 50% of male neurodevelopmental patients have hypermobility. So this was just really a bit of a background to actually the science, but this is why we should all be interested in these conditions. And I forgot to say that hypermobility is really common. In terms of symptomatic hypermobility, there is no good epidemiological data. But we know from the ALSPAT birth cohort that about 20% of adolescents have generalized joint laxity. And we know from population studies of all ages that about 20% of people have hypermobility. So we can be fairly reassured that probably 1 in 4 people have hypermobility. The number of people for whom that is a problem, there is no good epidemiological data. So I have, since I started my academic clinical fellowship in 2009, which now seems a long time ago, I have been pondering the question of why do people with a connective tissue disorder, why are they more vulnerable to panic or anxiety? And with colleagues wrote a kind of an opinion piece about that, essentially expressing that it is our belief, and I'm going to show you some evidence to support this, that people with hypermobility are constitutionally vulnerable to anxiety disorder because of the way that connective tissue affects cardiovascular and autonomic functioning. So the first study that I did in this disorder was a while ago and published in 2012, when we looked at 72 healthy individuals and scored them very loosely in terms of whether they had any hypermobility or no hypermobility, which divided the group nicely into half and half. And we found that the hypermobile group had bilaterally enlarged amygdala. These were otherwise healthy individuals, no demonstrable anxiety disorder. We also found, interestingly, that there were areas of parietal lobe that there were smaller volumes the more hypermobile you are. And that finding is interesting in terms of the evidence about hypermobility and dyspraxia, which is there's a very strong link between hypermobility and dyspraxia. So I asked you how many people in the room are familiar with recognizing and identifying hypermobility. We're going to now talk about hypermobility's, well, it's almost twin, but cousin, postural tachycardia syndrome. How many people here seeing patients with postural tachycardia syndrome feel confident in diagnosing postural tachycardia syndrome? So lots of people seeing it, less people feeling confident. So there's been a lot of work that shows that probably when we use the old term joint hypermobility syndrome, that about half of the people with joint hypermobility syndrome would meet diagnostic criteria for a particular type of orthostatic intolerance called postural tachycardia syndrome. And then we know from collaborations with Valeria Iodici and Professor Matthias, formerly at both St Mary's and Queen Square, but latterly just at Queen Square, that about 90% of the patients that they're seeing with POTS have hypermobility. So there's this very tight link. And POTS is actually very easy to diagnose. So all it is, and I have some really good data that I'm going to show you in a second that shows what seems to happen in non-anxious, non-hypermobile people in terms of what happens to their heart rate when they stand up. But to make a diagnosis of POTS, you need a heart rate rise of 30 beats per minute on standing, or a consistent heart rate of over 120 beats per minute on standing. And this can either be diagnosed by a tilt table, and I have a tilt table at one of our research facilities at the Royal Sussex County Hospital in Brighton. But in terms of the diagnostic guidelines, it can also be diagnosed, with a pulse oximeter on an active stand, which is lying down and then standing up for 3 minutes. So the symptoms of postural tachycardia syndrome, as you can imagine, are things like palpitations, dizziness, lightheadedness, and there is a huge phenomenological overlap between the symptoms of postural tachycardia syndrome and anxiety. And I'm going to, and that there's a debate, is it the same thing? I think they're both brain-body interactions are similar, and we all know that the physical symptoms of anxiety that any of us experience if we have a disorder, or whether we just experience anxiety from time to time, that the somatic symptoms of anxiety are driven by the autonomic nervous system. So autonomic nervous system dysfunction is very closely linked to joint hypermobility. And we think that is likely because in the connective tissue problems that you have with joint hypermobility, you have floppy connective tissue in the peripheral vasculature, that if you go from lying to standing, you have poor venous return. And through Starling's law, with poor venous return, in order to maintain cardiac output, your heart rate has to go up. And you will see it in patients with hypermobility. Some of them, if you ask them to go from lying to standing, which I do all the time in my studies, their feet go red. And if you put someone on a tilt table, you can notice this venous pooling. So, as I said, those things. So now I'm going to talk you through, actually I'll go back before I talk you through some of the work that I did in my PhD. And I want to be very clear that the work that I did in my PhD was not on perhaps, say, the type of patient that you were seeing in tertiary clinics. I looked at 80 people, and I recruited them not on the basis of whether they had hypermobility or not, but on the basis of whether they had anxiety. And so I looked for 40 patients with anxiety and 40 patients without anxiety, and then I sampled them into either being hypermobile or not in each group. So I had 4 groups, and I measured their degree of autonomic symptoms, particularly orthostatic intolerance. We did interoception measures. We also used something called a phonometer to do beat-to-beat heart rate and blood pressure, lying and standing. So I had signs of orthostatic intolerance as well. We put them through a brain imaging paradigm involving false physiological feedback and also emotional phases, which I'm not going to dwell on too much, but I'm going to really talk to you about the symptoms of orthostatic intolerance in this group and also the signs of orthostatic intolerance. So I don't seem to have a pointer, but hopefully you can see that the left axis here is symptoms of orthostatic intolerance. So this is self-report of how many symptoms of orthostatic intolerance. And we have about 80 people here, half anxious, half not anxious, half hypermobile, half not hypermobile in each group. And what we can see, as you would expect, because there's quite an overlap between symptoms of orthostatic intolerance and anxiety, that the patients with anxiety have significantly greater symptoms of orthostatic intolerance. And in a much larger, in a 400 patient sample, I found that orthostatic intolerance symptoms mediated the relationship between anxiety and hypermobility. What we then look at is that difference in terms of symptoms of orthostatic intolerance, in terms of whether you're anxious or not anxious, hypermobile on the right, not hypermobile on the left, is much greater. There is an interaction when we take into account hypermobility syndrome. And then if we think about if we think about actually what is happening in the body, so that's the symptoms that these individuals that were experiencing, a population that were not recruited on the basis of having a diagnosis of hypermobility. We found, and I can't actually read, so I'm going to have to come and stand over there. I hope, is the mic working? Can you hear me? Yeah, so in an anxiety population, if we do the lying to standing heart rate and we don't take into consideration whether they're hypermobile or not, we find that the non-anxious people, when they stand up, this active stand test, their heart rates go up on average from baseline by about 10 beats per minute. So those are the non-anxious people. When we look at people with anxiety, we find that when they stand up, the mean change in heart rate is significantly higher at nearly 17 beats per minute. And these are not people who have been selected because they have postural tachycardia syndrome. They ultimately are on and I'm not going to invent it, but they are sort of on a POTS-like spectrum. Not many of them met full criteria for POTS, but you can see there is a far greater increase in heart rate on standing. And then, like the symptoms of orthostatic intolerance, there is a clear interaction in terms of the relationship between change in heart rate on standing, so the objective signs of orthostatic intolerance and anxiety, there is a clear interaction of hypermobility. So we see there that the anxious hypermobile people on average experienced a heart rate rise on standing of 20 beats per minute compared to non-anxious, non-hypermobiles experiencing about 6. Anyway, so I need to get to the point quite soon. So what I did was my colleague, Professor Sarah Garfinkel, we were both thinking a lot about interoception, and she coined this idea of interoceptive trait prediction error, which is the difference between your objective interoceptive accuracy and your subjective interoceptive sensibility. And she found that correlates with anxiety. So I thought, well, I've got a very specific measure of interoception here in terms of autonomic interoception. What is the relationship between if I Z-score my objective scores and my symptom scores, what do I get? And I find that that this is related to anxiety level. So on the left, the more your symptoms exceed your signs, so if you have a negative prediction error, the greater your level of anxiety. So this mismatch between what you think is happening in your body and what is actually happening in your body predicts anxiety level. And then if we take that one step further and look at the brain, so these are functional MRI images, what I looked at very specifically in this contrast was hypermobile people, so the 40 hypermobile people that I had, and I looked at the hypermobile anxious people versus the hypermobile non-anxious. And the difference in looking at emotional faces was in anterior insula. And that activity in anterior insula correlated with anxiety level, as you might expect, but also both the activity in anterior insula and the anxiety level correlated with that error, this mismatch, which we can think about in a predictive coding way. That correlated with both, and using a kind of Baron-Kenny mediation analysis, we find that it is the autonomic prediction error that fully mediates the relationship between anterior insula and anxiety level. So what I propose is that there are many mechanisms, a complex brain-body interactions that link joint hypermobility to anxiety.
but essentially physiologically vulnerable to autonomic hyperreactivity, but have imprecise autonomic and interoceptive prediction. I haven't gone into them, but there are abnormalities in connectivity, activity, and structure of insula and amygdala, which coupled lead to somatic hypervigilance and potentially misinterpretation of threat, leading to anxiety.
And using that model, I have received funding from MQ and Versus Arthritis to develop a new non-drug treatment that targets that prediction error. So the idea is to make people better at detecting what is happening in their internal milieu through interoceptive training, and at the same time use psychological and cognitive approaches to help decatastrophize internal bodily sensations to reduce that autonomic prediction error, and with the aim of reducing anxiety in people with hypermobility. And we are currently recruiting for the first phase of this study, which will be a randomized controlled trial now. And part of that will involve some quite fancy but exciting real-time fMRI neurofeedback, where we hope to reduce activity in anterior insula through biofeedback in real time and show the participants how that is done in the brain. I would just like, those are my details if anyone wants to contact me, and I'd like to say thank you to my collaborators, mentors and supervisors, and also to very warm thanks to the 600 participants who took part in my PhD study. Thank you.